significant opportunities through our physician surveys that care management may give us some ability to reduce burnout. Our pharmacists will provide a critical part of our team and finding ways that they can help achieve that better treat to target and cardiovascular disease is the goal for the coming year. And you know, speaking of setting goals, we talked about it for patients. I think it is setting goals for ourselves. So that's why we're trying to set a stretch goal within care management and then learn from that. So I think that is everything. Take questions.
I was just wondering what your care management caseloads look like, and if you've been able to figure out your cost per patient per month or annual cost per patient. And does that caseload, is it for the team or is it by team member?
So we haven't looked at the cost per case manager or care manager. We typically, the care managers manage somewhere between 60 and 80 patients per caseload. And the program itself is around $2 million. So we haven't actually broken down into the per
Cost per
case
patient?
Cost per patient. Yeah.
So you mentioned it, but one of the key factors here is really identifying who are the patients that you should be focusing on, kind of developing the criteria. And you mentioned you're identifying patients who are in the hospital or recently discharged from the hospital. But you also mentioned that there's software out there. Are you testing any software to help you identify those patients?
Yeah, as part of the Anthemesio, we have used their DXCG scoring for those patients. And patients who have 2 chronic illnesses and have a DXCG score over 4 are people who we assign care managers to and try to engage those patients. Sometimes it looks like it worked. Sometimes it looks like the DXCG score wasn't right because they're claims based, and I don't think they probably had ways that at least Veris, which is the company that tried to validate the measures, and Mike Cooper, our managed care director, has been working with WA at their ability to give us DXCG scores similarly. And I think that when we get it in different silos, it's still usable. Ultimately, it would be the best if we were able to institute it even with some of our own data as well as the payer data. If we could get an amalgam of all those, because I think that it would be a way of. I think that when you get the mixture of both the data from the insurer and data from us, I think it would probably have more truth.
Yeah, because I think it's really, like you say, 2 plus 4 plus is one way to do it, but then the polypharmacy, some behavioral health type things are going to be critical to identify the highest of the highest risk, and it's really about focusing those resources at the highest risk patients. So it really software that can do that. Whoever can develop that very quickly using either electronic health data along with claims data, it seems like that's really the best way to do this.
Jose, some people here know Dr. Agnihotri, who's now down in San Diego. He was here, that's correct. And he had developed the start of a predictive model to do this. And I evaluated it earlier this year, and it really, as far as cost, it was like a shotgun. There was no correlation, so I played with the model. And now it has pretty good correlation. And what they found, actually, is that the ones that scored the highest, as far as care management, those patients almost invariably didn't need a care manager because they're really plugged in. It's actually the next level down, so it wasn't the people with the highest score who really needed your help right then. It was this layer right below it, which we found really fascinating because when we gave the names to the physicians, say, are these high risk? They go, oh yeah, I recognize, I don't even have to look it up, I know these people. But that wasn't the people that really needed this the most.
Interesting.
Very interesting.
Yes.
I'm also happy to share with you recent evidence or already tested algorithms that we just received yesterday from Stephen Chen and his USC Comprehensive Medication Management work. He had to talk to folks from RAND this past week to get permission to share it more broadly. And the way we agreed he could push it out would be to kind of have a no-cost licensing fee. In other words, he's not going to just publish it out in the universe for people or vendors to pick up, but more importantly, broker the information with institutions like yours that would just take it in to do a better job to create efficiencies within health systems in California. So I'm happy to share that information because we're going to be pushing out many of these very same tenants. And he had a CMMI grant from the federal government, and he's tested it over the last 3 years and has something that's ready-made that you may want to look at as evidence, as outcomes, and as how-to guide to better inform your process. But I just wanted to congratulate you and thank you for doing this for your large number of patients in our region.
Thank you. I look forward to that.
Thanks, Tom and Bridget. That was really fun to listen to, and I found myself thinking, what a fun place to work, that you guys seem really invigorated by this instead of, you know, as you say, it can be easy to feel burnout or feel like you're not making an impact, but the energy that you bring to it was very inspiring. I found myself thinking while you were talking about your care managers, your care coordinators that sound like they're, you know, pretty high-level nurse care coordinator, about health coaches, and then you mentioned later on that you were looking kind of at health coaches, and there's a variety of different models obviously for that, but some have been built around the MA, some have been built around, you know, lay health workers, and I'm just wondering what you guys are thinking about. I know we have a medical student right now who's doing her master's thesis on using a health coach actually in the emergency department for the patients with diabetes and high blood pressure who land there for a variety of reasons, not just because of their diabetes, but who are noted to have their diabetes or blood pressure not in control. So I'm just kind of wondering what you guys are thinking about.
Teachable moment.
Exactly.
There are a lot of different models out there. We are visiting UCSF in July. They have a program that feels very close to what we've been able to do this from the UC Collaborative and sharing best practices. So we're going to go down there and check out what they're doing. They use health coaches. They're non-licensed. They're not MAs. They're somewhere in there. We have a couple in our education portion of the program. We have some community health program reps, which are also actually health educators with a 4-year degree. And I feel like that would be a really good fit because that's where their education is focused. But there certainly are a lot of different models to learn, and I don't think that we're locked into what we're going to do. But we want to have some kind of a balance between the health coaches that are in the clinics as a face of what we do, and then they can escalate the patient up to a care manager license, either a social worker or a nurse as needed.
Yeah. And the face in the emergency department, I think, is also part of what they're seeing at Highland. So that's a Highland.
Especially for the patients who don't go to the office.
Exactly.
Right.
Making
Just
that connection, and then having that be connected. I mean, one of our goals is to really make the system operate like a neighborhood, so that
exactly.
in that office, that the person who's doing that coaching, excuse me, in the emergency room, would say, you know, there's going to be somebody just like me who's going to be at your doctor's office, and we'll have a little more time for you, and they're going to work with you and your doctor, and if you have something special, we actually, if there's something that comes up along the way, we'll have somebody who's like a nurse, or if there's things going on in your life that are a big problem and a barrier, we'll have a social worker who can work with you. Because it may take multiple times until somebody is ready to like say, yeah, I'm ready for that.
It's great. Thanks.
Do you measure the language preference of the patients that are identified, and how do you have the care managers, or do they have bilingual skills, and how many and which ones?
So we have 2 of our care managers are Spanish bilingual. And we have a health educator that speaks Punjabi. So we utilize those staff as much as possible for, you know, obviously we direct the patients to that resource.
Plus, we, you know, it's not quite as ideal as that, but interpreting services for us,
Yes.
then we can extend. I mean, you add another person into the communication chain, but you know, it's not telephone. It's usually they can be in person when we need them, and they're our employees at UC Davis, and we're not necessarily utilizing an expensive AT&T resource.
It's not about language, but I also want to mention that we're working with our health system on using a program where we can have video from the clinic to the care manager, or even they tell us pretty soon it will be from the patient's home to the care manager's desk, so that we can talk to patients face to face. I'm sure that's right around the corner.
Thanks. Thank you.
So, Jose, we need to fill out the
Great. Yeah, Alan just reminded us that we'd love for you to fill out the evaluation form. It really is critical for us and for those who get CME credit. And we are providing CME for this. We need that evaluation form to be able to provide that for you. And again, thank you for participating. This is really crucial for us because it is about your participation in helping us understand what are the best interventions we could be doing to assist our patients. And also, we really are interested in getting your support in both getting the hypertension algorithm out to your physicians and clinicians and getting feedback on it, as well as if you're interested in disseminating the survey that once we get it validated from Dr. Chen, I think it should be any day now, and we'll be then wanting to work with you if you'd like to use that as part of your program on hypertension management. Anything else? Any other questions? Anything else that the head table would like to comment on? Thank you again for your participation, and have a safe and cool trip out there. Back home.
So, this is a lot easier if you can fill it out now. Somebody can enter it for you. So.